Good morning, everybody. I'm glad to introduce to you Amy Hiller. She's a first-year resident with us, and she will talk about today's topic, inguinal hernia.
Good morning and welcome to today's lecture about inguinal hernia. So we're going to talk about the epidemiology and risk factors, the basic anatomy, classification, diagnostic modalities, and we'll focus on the surgical techniques, and then complications, emergency treatment, and the take-home message. So inguinal hernia is a very common disease with a lifetime risk of 27 to 43% in men and 3 to 6% in women. Femoral hernias are more common in females, and inguinal hernia repair is one of the most common performed surgeries worldwide, with over 20 million repairs per year. Nonetheless, there is no standard care for inguinal hernia patients, but there are multiple guidelines, for example, the EHS and the IEHS, which use the Oxford hierarchy grading system, and then there is the hernia search group, which uses a different grading system. They also focus on different subjects. For example, the IEHS focuses more on technical details, whereas the hernia search group focuses more on therapy recommendations. This presentation's content is mostly based on the hernia search group guideline. Risk factors for primary inguinal hernia. There are different evidence levels, and risk factors with a high evidence level are inheritance, male gender, and age. And maybe surprising that chronic cough has a very low evidence level. Risk factors for recurrent inguinal hernia with a high evidence level are female gender, direct hernia at the primary procedure, and of course limited surgical experience. Now it's crucial to understand the basic anatomy if we talk about this topic. So here you can see a picture of the abdominal wall. So firstly we have the aponeurosis of the external oblique muscle, then the internal oblique muscle, the transverse muscle, then follows the fascia of the transverse, and then the peritoneum. And the same from a sagittal point of view. So again, the aponeurosis of the external oblique muscle, the internal oblique muscle, the transverse muscle, the fascia, and then the peritoneum. It is also important to know the nerves of this particular region, as we see later on when we discuss the complications. So the most important nerves are the iliohypogastric nerve, the ilioinguinal nerve, and the genital branch of the genitofemoral nerve. We differentiate between indirect inguinal hernia, which protrude lateral to the epigastric vessels through the internal inguinal ring, and then we have the direct hernia, which protrude medial to the epigastric vessels through the so-called Hasselbalch triangle. And then down below you see the femoral hernias. As for the diagnostic modalities, clinical examination is standard in diagnosing inguinal hernia with a sensitivity of 75%. But there obviously is a diagnostic gap, especially for obese patients and femoral hernias, and also for multiple hernias. Then we can use ultrasound, CT scan, or MRI. Ultrasound has also a very high sensitivity, but it also has a very high inter-observer variability. So we rather use the CT scan because with the CT scan we can also do the pressure maneuver, and then we see very small hernia. MRI we would only use for young patients to spare them from the X-ray. Now on to the surgical techniques. So they all pursue the same endpoints. Firstly, repositioning of the hernia sac into the abdominal cavity, and second, the strengthening of the posterior wall of the inguinal canal. So here you see an algorithm of groin hernia repair. So if we have a patient with an inguinal hernia and who underwent a previous abdominal surgery, we would rather choose an open repair. There we can choose between a mesh-based repair, so either Stoppa or Liechtenstein, or we can choose a suture repair, for example, the Scholdeis. If we have an inguinal hernia and no previous surgery and it's unilateral, we would either do open or endoscopic. If we have a femoral hernia, we would rather do an endoscopic approach, and if it's bilateral, we would go for an endoscopic approach since we don't want to do two separate incisions. If we have a recurrent hernia, we would choose the opposite approach. So if we initially did a Liechtenstein, we would now choose an endoscopic repair. But really, it is an individual repair, and it depends on the surgeon's expertise, hernia size, comorbidity, etc. Another possibility is watchful waiting. We can choose that for asymptomatic compliant patients, but the crossover rate is almost 70% at 10 years, with the main reason being chronic pain. And emergencies are rare. So now the techniques. So the Schuldeis repair is a suture repair. It's an open approach with an inguinal access. It's basically the doubling of the transverse fascia and the suturing of the abdominal transverse and the abdominal internal oblique muscle to the inguinal ligament. Now the Liechtenstein repair is also an open approach with an inguinal access. It's a mesh-based approach, and you place the mesh between or behind the aponeurosis of the external oblique and in front of the internal oblique muscle. Then the third open approach is the Stoppa approach. It's an open procedure with a median incision, and you place the mesh preperitoneal. It's useful for combined ventral and inguinal hernia repair. Now the endoscopic repairs. So firstly the TAP, which stands for totally extraperitoneal. It's a minimally invasive approach, and you use an extraperitoneal access. So you dissect the layers, and then you make yourself some space, and then you place the mesh preperitoneal. A quick excursion to this. So its operative time, as you can see, decreases with the amount of cases you do. And also the recurrence rate decreases with the amount of case numbers. At this point, I want to mention that you need more than 100 repairs to achieve the same outcome as, for example, an open mesh-based repair. And that's about 40% more than what you need for a Liechtenstein. And then the second endoscopic approach is the TAP, which stands for transabdominal preperitoneal. It's also minimally invasive, but you use an intra-abdominal access, and then you place the mesh at the same location, preperitoneal. Last but not least, we have the robotic inguinal hernia repair. Here we have enhanced visualization, superior dexterity and precision, but on the downside we have higher costs and longer operative time, at least primarily, and also a longer learning curve. The robust study, they compared the laparoscopic TAP to the robotic TAP, and as we can see, at the beginning they almost needed the double amount of time to perform the procedure, but at the end it was even faster. But a limitation to the study is that the surgeon who performed the robotic TAP already was a skilled laparoscopic TAP surgeon. And just to illustrate the costs, so the main difference lies in the medical device cost, which basically represents the purchase and maintenance of the device. And then the last slide to the RoboTap is this one, and they compared the outcome 1 month after surgery. They compared pain, restriction of activities, and aesthetical discomfort, and they did not see a significant difference between RoboTap and laparoscopic TAP. Now to compare all the mentioned procedures, so the endoscopic repair has, again, less initial postoperative pain, less time to return to work, and a lower recurrence rate, but higher costs. But if you consider what I just mentioned, so the socioeconomic point of view, at the end, there's similar costs. And then, in general, there is a low complication rate overall, but some of them are debilitating, like chronic pain with 10%, and also the recurrence rate, which is higher with the suture repair than with the mesh-based repair. And all the other complications are rare. Risk factors for chronic postoperative pain are young age, female gender, preoperative pain, and pre-existing pain syndrome. And of course, there are surgical risk factors like less experienced surgeon, mesh type, open surgery, etc. As for prevention and management, the hernia surge group does not recommend to primarily resect the nerves because it does not decrease the incidence of chronic pain, but they do recommend to resect the nerves prophylactically if you have, during the surgery, damage to the nerve or if the nerve interferes with mesh positioning. And then real quick to the emergency hernia repair. So indications for that are incarceration, which is the inability to reduce the hernia mass into the abdomen, and strangulation, which means that the blood supply to the herniated mass is compromised. Risk factors for those two are hernia-related hospitalizations in the year preceding the hernia repair, female gender, and femoral hernia, especially on the right side. And you need to know that emergency hernia repair is associated with a higher mortality and morbidity with certain risk factors present like age over 65 and incarceration for more than 24 hours and so on. And then again, the hernia search group does not support an optimal surgical approach. If you're concerned about bowel viability, you need to visualize the bowel, and you can do that by either hernia sac laparoscopy, formal laparoscopy, or laparotomy. And then the take-home message, so inguinal hernia is an extremely common disease, but there is still no standard care. You can either do watchful waiting, that's an option for asymptomatic men, but you would choose surgery for complicated hernias, women, symptomatic patients, and emergencies, but at the end it's an individual repair. And experience, as we saw earlier on, is an issue, but the challenge of postoperative chronic pain and recurrent hernia remains. Thank you for your attention.
Thank you for the nice talk. What about in the emergency settings? If you have an incarcerated small bowel, you need to resect, or even if you don't need to resect, do you have any issues with placing a mesh in the acute setting?
I have no problem to put in an emergency situation a mesh. The infection rate is very low, and the data supports this.
Thank you for the talk. I have another question regarding the size of the hernia. And did you see there's a limitation, for example, TAP, regarding the size of the hernia? Because there are surgeons that say big hernias can't be repaired endoscopically and should be done open.
For inguinal scrotal hernias, I am a little bit careful to do the laparoendoscopic approach, because you have, as soon as the hernia has a size of, the hole of over 3 to 4 centimeters in the scrotum, the reposition is sometimes quite difficult and dangerous for the vessels. And also you need then a good mesh fixation. And you have the risk of the bulging of the mesh that can happen. So it's also a little bit a tailored approach that you have for every patient that you have to see in the CT scan. But as soon as we have an inguinal scrotal hernia, then I prefer to do the open approach. Or if it's really very big, then to do the stopper. Any other question? Thank you for the very nice talk.